Welcome to our virtual space, where thought leaders who, in a variety of ways, have committed themselves to improving our lives share their work, perspectives on current affairs, and what brought them to where they are today. My name is Rob Liu, and this is the Exchange. So, Bindu, thank you so much for joining us in the Exchange. For us, it's a real opportunity to hear from someone on the front lines that have been working in a hospital setting at the Hackensack University Medical Center with patients that have been affected by COVID-19. So one thing I'd love to sort of help our audience understand, there is what happened with COVID, but placing that aside for now, what is it that you do as a physician? What is your focus?
First and foremost, thank you for having me. It's been tough times. It has been strange times these last few months. And as a background, I am an infectious disease physician. I I finished my studies. I did my fellowship at Robert Wood Johnson in New Jersey, New Brunswick. ID has been fascinating, and the journey towards infectious disease basically came along in my second year of internal medicine residency, with my mentor being Dr. Fisher, who was one of the ID physicians at our hospital. Just the variety of infections that we saw at that time during my training. HIV was still very prevalent. It still is, but it was that time where the new protease inhibitors were coming out. And we saw a lot of HIV patients with very varied diseases. And I think what kind of just stuck with us was probably related to the infections that we saw in my HIV patients from Central America, for example, was very different than what we saw from the patients who were coming in from US. So just the various different infections from different parts of the world is probably what enticed me into this particular field at that time, because I thought the whole concept of history taking was to the extreme. Like, you really had to know what the baselines were, where they were coming from, what their occupational history is, etc., that made that epidemiological link to get into where that particular diagnosis was from that particular patient. So that kind of interested me into infectious disease at that particular time in internal medicine. And then I followed it with my fellowship. And then once I've been here at Hackensack now for 20 years, this particular event in March was something that we had not prepared for, not studied for, not thought that we would actually see it during our lifetime. So it was something really interesting. I
Mhm.
have to say that's a very small word for what we actually went through.
No, of course. So, Bindu, am I correct that you treated the first confirmed COVID-19 case in New Jersey?
That is correct.
Wow. So, so can you tell us, I mean, what that was like when you encountered this patient? Um, what was that like? Was it so puzzling? Did you have a clue of what this could be already, or was it a complete mystery at the time? What was that encounter like as the attending physician?
So going back to early March, we were called for a consult for a patient who had pneumonia. Not every time does ID get called for just a simple pneumonia patient, right? So it was something obviously that triggered the emergency room physician to have a suspicion of some abnormality that could be present. When we saw our gentleman, he had the fevers, he had the shortness of breath, he had the breathing very fast, having a cough, having muscle aches and fevers, very flu-like symptoms that were present for about a couple of days. But he didn't have any travel history. He was not traveling to China. He was not coming back from China, though he did mention he had been at a big medical conference. And he himself is a healthcare provider in Chinatown, with exposure to patients in Chinatown. But again, that particular day, we had him on precautions for possibility of the disease, but never did I think that he was going to have it positive. His CAT scan was slightly bit abnormal. He definitely had a pneumonic patch, a little bit of whiteness that we noticed on his CAT scan. But again, treated him for a regular pneumonia, but something obviously triggered our staff at our hospital in the emergency room department itself as soon as he came in to have him tested for COVID. At that particular time, there was really no treatment offered at that point, given the fact that we didn't have a diagnosis. But just the overall presentation of having a young, healthy adult with a significant symptoms of respiratory illness and yet not a significant X-ray finding, not a massive pneumonia, just a small speck of around ground glass changes in the pneumonia, was a little unusual. We placed him on routine antibiotics, thinking it would be a routine bacterial pneumonia while waiting for these particular tests to come back. When the test did come through a couple days later, it was frightening. I have to admit, it was frightening the upfront, not knowing how to manage a particular patient with this kind of illness. Never experienced it, never had any patients who had been here before. Even though we had read so much and we had heard so much on the news, never did we think that a virus is going to come from China to New Jersey, to our hospital, to my patient. So just digging down to that particular concept that this could be happening right here, right now, was a little scary. He definitely, over the next few days, had increasing, worsening shortness of breath and cough and fevers that persisted. That led to us reaching out to the experts in the field at CDC. So Dr. Tim Ukei basically helped me out with my decision plan, knowing that it's a brand new disease. I didn't want to take a chance. I didn't want to jeopardize the health of my patient. So
Yes.
obviously getting access to the gurus was the way to go. The other thing I have to admit, and I humbly admit, obviously the patient taught me a lot. The patient's access to the World Wide Web actually helped us a lot. His associations with his family members and friends way back in China who were actually dealing with this situation gave us input and insight. Having experienced so many patients upfront already, obviously gave us a way to help this particular gentleman in our hands. As a few days progressed, his fevers and his cough still progressed. His breathing definitely got worse. His CAT scans got worse, unfortunately. But simultaneously, as soon as we had the diagnosis of the disease process, we simultaneously, based upon the data that we had, applied for availability of medications to Gilead to try and help get remdesivir for him. We had already started the process, and his family also started the process simultaneously by trying via the social media and all help that they could get to try and get access to the antiviral agent, which at that particular time was still all in experimental investigational product. It still is an investigational product, even though it's received the emergency use application. It's still a drug that has been approved on an emergency basis, knowing the positive outcome that we have. So having applied to Gilead, again, it's a brand new process for us, for me, and for my pharmacy staff who helped us out getting through this particular process. We applied for his medication through the Gilead. It came through, he got the medicines, he did very well subsequent to receiving the antiviral therapies. And I'm glad to say he's doing a lot better at home.
Fantastic.
So yeah, he had a really good outcome during this whole process. So it was a very, I guess, indelible experience in my mind. Nothing that can obviously, take away from that first patient. But thanks to him and thanks to learning through the process, I definitely was able to help my team members subsequently in this process, which was tough the next few months.
Yeah. So with New Jersey ultimately having more than 300,000 cases, did you then at the medical center see this gradual tsunami of cases
Oh,
in
yes.
Hackensack?
Oh, yes. Gradual, I don't know.
Oh,
To
really?
us,
Was it really a big?
it seemed like an impact.
Okay.
But yes, those 6 to 9 weeks up until middle of May, so nearly 3 months, 12 weeks, was an intense change that we saw throughout the hospital field. Like in maybe the first 2 weeks where we still had regular patients coming in, that patient suddenly, the whole concept of any patient walking in could now have COVID. Any side effect that we saw, change in the respiratory status, no longer were we thinking of routine pneumonias as first line. It was COVID till proven otherwise. Anybody walking in had to be on precautions till we knew for sure that they didn't have any particular problems. Those first few weeks of just the unknown, I have to say, was scary, but it was the collaboration between all the modalities that we had between both clinical and non-clinical administration, IT, pathology, lab, housekeeping, janitorial services, biomedical engineering. Everybody had to have had a say in what needed to be done to make the hospital and our center adapt to that particular infection that we had over these next few months.
So did your center experience some of the shortages of the personal protective equipment, the PPE, that other hospitals had?
So luckily we didn't. Not to say that I don't think we had it. I think we definitely, if you were to ask the same question to a supply chain person, I'm sure they're going to say, you don't know what we went through to get the supplies for you guys. But yes, were there periods where there was nothing available? No. Were there periods that it was rationed, that we had to reuse, resupply? Yes. So again, I think also having the administrative and the biomaintenance, etc., people tell us on a day-to-day basis as to what we had and what we didn't have, and how to adapt to that on a day-to-day basis. Sometimes even hour-to-hour basis was important. Testing strategies and testing availability shortage, yes, but PPE, I have to say, we had it. We were given the supplies that we needed. How did the hospital acquire the supplies? And did they have to scramble for it? I'm sure they did.
Yeah, no, I'm sure. So a lot has been made of just the enormous stress that this placed on physicians, on nurses, on all the healthcare givers. And so, can you speak a little bit to what that was like? Because the way it's been described, it's almost like a combat sort of situation.
It
Right?
was total war zone for us. So let's talk about physicians first.
Yeah.
From physicians' perspective, it was the number of staff that were coming in, the number of people who were coming in to the hospital had skyrocketed so fast that walking into the hospital, the emergency room physicians, the first responders that were there were lots of physicians who got sick during this whole 12-week course of illness that we had. So again, the staffing at that particular emergency room was affected. People had to be deployed within the emergency room to different areas. We had a huge triage tent that was put out specifically for COVID, because obviously the prep that we had to do, the PPE that we had to do, had to be well utilized in the same spot. So there was this MSAT unit, which is a mobile unit that we had, that the physicians were constantly in the PPE for the full 8 hours. The nurses were full PPE in 8 hours, so that those patients had to be in one particular area to be able to be visualized, taken care of simultaneously. Going in and out again causes a lot of PPE loss, as well as the number of exposure to nurses as well as the physicians to come into play. So again, monitoring the number of people coming in on the staff on the shift had to be very rigorously taken, because the number of doctors and nurses available at any given time point was very few based upon the number of patients coming in. The workload with the patients coming in was extremely high.
Yeah.
The ICU shortage, the ICU requirements was extremely high itself. People were coming into the emergency room and we were intubating them. It seemed to us everybody coming in was getting intubated. It was a very high flux of patients in a very severe respiratory illness that require intubation, which meant one-to-one patient and nurse ratio, which meant a very close possibilities of the nurses and physicians associations with them. It also meant going into an ICU unit. So our ICU unit suddenly became from a simple 20-bed ICU for a medical ICU and CCU ICU to 116, I think, or 117 patients on ICU at one day. So the number of beds and the number of units which required ICU care was very high, which meant we needed to have ICU doctors, which we didn't have ICU doctors, so many. So many of the internal medicine doctors were deployed to work as ICU physicians. Many of the surgical ICU doctors were pulled in to manage medical ICU patients. Many of plastic surgeons, many of the pediatric doctors, pediatric ICU doctors were pulled in and deployed as adult ICU doctors. So there was a lot of redeployment of physicians from different fields to come
Mhm.
and manage COVID. We also had, I think, one very important piece of information, that one piece of physician recruitment that we did was there were physicians who were volunteering their time to us. Either they had retired or they were not seeing patients because the patients were closed and they wanted to give time to us. We actually just had physicians communication doctor. There was one special physician communication doctor was on the floor all the time, whose main job was just to call the family, update the family constantly. So they would hear from the treating physicians, get the data, deploy them out, and then have the physicians speak to the family on a regular basis. So all these physicians were deployed. These were voluntary physicians. Some of them had retired physicians that they came in to help us with it. So we had a lot of new physicians on board, and everybody became, regardless of their specialty, everybody became an infectious disease doctor. Everybody became a COVID doctor during those times. Same thing with the residents also. There were lots of residents who had to take time off and get furloughed because of illnesses, but then they came back in and put in their 100%, 150% during that time frame.
Yes, of
And that was the
course.
nurses. Yeah, and then the nurses, we had a lot of travel nurses from all over, from Utah, from Arizona, from Florida, who came in to help because there was just a very big need of nursing care that was required.
So of course, all of this is so fresh, right? And while New Jersey has certainly improved in terms of its situation, as we all know, there are fears about another spike, etc. What may possibly happen? It's maybe a little bit early to ask this kind of question, but Bindu, in the system, and maybe focusing on the medical center that you're at specifically, is there one thing in particular that you or the center has learned about what happened that you feel now has you better prepared for this? Is there a new protocol, a new way of thinking about mobilizing stuff, a new way of thinking about even mobilizing PPE and how you get PPE? Have there been changes in the supply chain, both human and otherwise, so that you're more able to respond to something like this?
So I think yes, absolutely yes. From the physician's point of view, from the physician's deployment point of view, this particular protocol that we use during this time frame has now been pretty much written up that in case if a surge occurs, we already know what which doctors or which physicians to reemploy, redeploy, and how do we do that. Our physician prevention and PPE guidelines that have come up has definitely also been put into notes now because obviously this whole COVID situation that came along made us make sure that we had something in writing for the next time round, which was protocolized, so that we didn't have to strive again to the same way that we had to do at this point. Our learning of wearing the masks, which wasn't the case earlier on, has become a guideline at this particular time. We at the center are wearing, regardless of whom we are seeing and whom we are examining, everybody who is in patient contact has to wear shields, has to wear eye shields, has to wear masks, etc., for prevention policies, for prevention of both the healthcare workers and, more importantly, prevention of transmission of diseases amongst in the healthcare facility, amongst the patients, providers, and the health staff itself. Regarding the PPE management, I think definitely the supply chain is very well aware as to what is to be expected and what is to be anticipated to be able to hopefully have enough to maintain X amount of months in advance. So I think they all have learned the lesson of knowing exactly, what is required. And also what we learned was how much amount was used to be able to predict the next time around. Like this time was literally arbitrary. How many did we use last week? How many patients are we expecting next week? And then kind of come up with a rough calculation as to what we're going to be needing. But now, having gone through this particular peak, if God forbid this peak occurs again, we know exactly what inventory we're looking into to be able to think about and plan accordingly as to what's going to be needed down the road. So
Of course.
yes, all those are put into writing in a protocol that we have to be able to adapt for next time.
So you've really shared with us insight into sort of the emergence, if you will, of COVID-19 in New Jersey specifically. But I'm sure our audience is probably a little bit curious about you as well. So going back in time to when you were a child, etc., were you always interested in things medical? Becoming a doctor a very long-standing goal of yours, Bindu? Is that a path you've been on for some time?
So I have to say yes, but I have to go back again a little bit more. So if you say as a child, I would
Yeah.
say in India, you are either a physician or you are an engineer. So that's the two common options that are kind of put to you. So if you are going into a science field, you're going to be either an engineer or you're going to be a physician. So in our home, it was going to be, oh, my kids are going to be physicians. That was my parents' fields.
Right.
But having said that, I definitely wanted to be a physician starting when I was in my sixth grade. I met with an accident. I had a 6 month stay in the hospital, so I had a very close association with the hospital at that particular time. And then my orthopedic doctor at that particular time kind of made me feel, who got me back on my feet, was my mentor. My first step, I think, of why I like medicine. And I always wanted to be, I'm going to be an orthopedic physician when I grow up. And that's the way I kind of went through my whole schooling, my undergraduate years, and then even in my medical school. So in India, I did my medical school in India. So in India, we have to, when we're doing our final years and we're doing our studies and our subjects in the final years, you really have to rank really high up on that particular field that you're interested in for your postgraduate studies. So surgery was I'm going to be an orthopedic surgeon, was what I had always thought about. So surgery was my favorite subject, orthopedic surgery was my favorite subject. And we went through that route. But during my clerkship, when I had to actually rotate through the orthopedic rounds, seeing the stamina, seeing the time and the hours that the orthopedic doctor had to physically address taking care in the operations, kind of said, okay, maybe I should look at something else also. So, and then came along that, okay, we're going to be coming to US because my dad had had retired from his army positions, and he had come to US, and we were all going to be joining him here. So my sister, who's also in the physician field, she was 2 years ahead of me. So she joined into a family practice residency program when she came here to US. And thinking about my options, I said either family practice or internal medicine would be probably more likely for a foreign medical graduate than a surgical field, because at that particular time, surgery for a foreign graduate was a little difficult. And then also during that time, I'd also done my clerkship in surgery, and I'd kind of thought, okay, maybe I want to get something non-surgical from that perspective also. So when I came here, I applied after my USMLEs, I applied for internal medicine residency. And then the first thing that the doctor asked me is, okay, why do you want to join this particular residency? And I said, I don't know how to drive, and this is the closest residency I can find. It was not all true, but it was quite a bit true too. The place that I joined was literally 5 minutes away from home. So I was dropped to the residency in the morning with my parents, and they would come pick me up in the night till I could learn how to drive. But that also happened. But so yeah, I did my internal medicine here. And then in the second year, as I mentioned before, my ID mentor, who I think who is a fantastic physician, a really great diagnostician, was very much into medical history taking. I think I learned a lot from him, and amongst my other mentors, the history taking part that came through with this particular field of medicine, I think, is what kind of got me into infectious disease. Just the way to kind of do the detective work in finding out why the fever's occurring, where the fever's coming from, and the very quick gratification that you get on getting the diagnosis, addressing the problems, and taking care of it, and having a good outcome, really got me into infectious disease in my internal medicine round. And then here I am.
Fantastic.
Yeah.
So this is a question I often ask. I'm not sure that I have a feeling I know what your answer will be. Quite often, as we look back over our lives, we come to crossroads where we turn left or turn right. And sometimes you can come to a crossroads, and let's say you turned right. But if you had instead turned left, in a parallel universe, an alternate universe, you could have become a completely different person and done something completely different. So I'm wondering, if there are alternative universes, is there a universe where if Bindu had turned left instead of right, you'd be doing something totally different? Is that possible?
I don't think so. I really don't think so. I loved medicine.
Your pathway to medicine was clear.
It was so clear to me. And even today, even after, oh my God, I have to do all these paperwork, I have to do the EMR, and everything has to be electronically done. At the end of the day, I am just super satisfied with what I do. So will I ever do anything different? I don't think so. Even the parallel world, I'm sure I would have found my path this way too. I really knew that this is what I wanted.
Fantastic. That's great. So here's another question then. When you're not being a physician, what do you do?
That's a different question. So I like to paint. I like to draw. I like to sketch. I do that. I've not had so much time into it, but yes, that's something that I do like to do. Arts and crafts have been something fun for me always. So when my kids are out drawing or whatever, I said, "Oh, I'm going to try that too." And then I usually sit down with them and do something else, whatever they're doing.
Oh, that's great.
That's one thing that I've definitely loved. The other thing is I'm trying my hand at gardening. Not many things are coming out of that particular garden. And it's been a very expensive tomato garden and very expensive organic garden that I'm trying to make. But
Right.
it's fun. It is really fun to do that part. So that's something that's a new love that I've started this past couple of years.
Yeah.
And I like to dance, if what I dance is called dance. But yeah, I like to listen to music and move around. So that's something that's fun to do. I do enjoy that. And I love to watch Hindi Bollywood movies.
Fantastic. That sounds great. So, by the way, I kind of love the fact that as a physician, of course, there's a lot of making with your hands, etc., that happens, and of course, the element of pastoral care it transfers into gardening, I think, very well. Right. So
I
you're
guess it's
sort of
nurturing,
taking
right?
care of your garden.
Yes, that's
Yeah,
true.
yeah, yeah.
That's true.
Fantastic. Well, Bindu, thank you so much for spending this time with us. I think that you've given us sort of a wonderful on the ground insight into what happened when this first case of COVID 19 appeared in New Jersey. And of course, we're all at this moment holding our breath that we don't have another really terrible surge. Though I think across the Sun Belt, it's looking poor right now. Um, the question is the degree to which that will percolate into the Northeast, right? And will we start to see numbers again?
Um,
Um,
yes, we are all worried about it. We are all actively looking forward for it. But I think we have a good handle on what we're looking at. We are hoping with the new vaccine studies that's going to be starting soon, um, with the newer agents, the newer clinical trials that are currently present, we hope not to have that much of a surge again. And definitely, hopefully, if we can get people to get vaccinated, vaccine trials is one thing, but getting them vaccinations is another thing. So, if we can get people in the clinical trials to get them vaccinated, we hope that we would have this particular surge attenuated and not as and not have this second war zone again.
absolutely.
Yeah.
So, Bindu, thank you so much for joining us on the exchange. It's really been a pleasure.
Thank you very much for having me. Thank you.